testing, which is more expensive. Sometimes we have to adjust the value to our clients while we got to run more expensive tests, right? And this can help us do that. Your specific test for aldosterone, you can do plasma serum aldosterone levels, usually measured in about 0.5 mils of EDTA plasma or serum by radioimmunoassay. Resting values usually are kind of little value except if you have primary hyperaldosteronism. So you should measure aldosterone should always be measured before and after ACTH stimulation to get around that interference, okay? Resting levels in dogs are really narrow range, 5 to 345. So these are picograms, so it really isn't a whole lot there. We haven't established the values in cats because cats just don't want to cooperate, okay? Now, after ACTH stimulation, your plasma aldosterone values at 1 and 2 hours post-ACTH should be at least twice what they were at the resting values to tell you if you've got normal levels there. Okay, the stimulation suppression test, you have the ACTH stimulation test, as we said. You measure your plasma cortisol before and after you stimulate with ACTH. Natural or synthetic ACTH can be used in the test, and there's not very much species specificity, and that you can use other species ACTH and stuff to do this with. Samples are collected in a clot tube, EDTA tube, or heparin tube, and serum and plasma, so you can use either one, are used in the assay, and depending upon the lab you're sending to it will vary as far as the protocols of how they measure it. But this is just showing you the test protocols. Usually now more often we can use the porcine, because porcine is actually one of the cheapest as far as these ACTH products are concerned. But we can use synthetic also. And you can see the route of administration and notice your sampling times. And in a cat, to try to get better specificity, we usually take more samples. Sometimes it works, sometimes it doesn't. Okay, and so what you're trying to do, what the test is based upon, is if I give ACTH to a normal animal, the cortisol blood levels should increase about 2 to 4 times the resting levels. That's a normal response. Okay. Now, if I give it to an animal which has, cats and dogs, hyperadrenal corticism or hypoadrenal corticism, you notice in hyperadrenal corticism, the pre-treatment cortisol will be usually a little greater with the hyperadrenal corticism. And what happens after I gave it? It might have multiplied significantly, didn't it? Whereas with hypoadrenal corticism, it's going to be low and you might get a little bit of increase, but very little, not anything like the normal. And you can look at the dogs as far as using this. So we can use it for both hypo and hyperadrenal corticism determinations. Okay? And basically this is just showing you the test results. If you can see, this is giving ACTH. And what about the top one? What does that tell me that animal had? That response. In other words, the normal response is this middle line right here. What's this animal got? That's a hyperadrenal corticism. What's this animal have? Normal. What's this one have? Hypo. Okay, and so that's how we determine, that's why we can use the ACTH stim for both determinations of hyper and hypofunction. Okay, so that's you. Now, the dexamethasone suppression test, as I say, there's 2 different ones. There's low dosage and high dosage. It just means low dosage is a lower dose of the dexamethasone. And it helps differentiate cortisol levels elevated by stress or chronic disease from elevations caused by hyperadrenal corticism. It's more sensitive but less specific than the ACTH stimulation test. That is, you can get, basically with the ACTH 10 you get fewer false negatives, greater false positives. But it is the preferred test for the diagnosis of hyperadrenal corticism in dogs. But guess what? They're kind of inconsistent in cats. But it does, if it works, it works. But the ACTH stim is the preferred test to use to determine this in the cat. Okay. Now what we're doing with this test is just to determine, do we have hyper or hypo, or do we have normal function? It's not going to tell us if it's primary or secondary. That's where we use the next one. You can go through the protocol. I'm not going to I don't ask, do I ask you all about protocol?
No.
No, but this is for your all's information. But what do you gotta make sure you draw before you do any of these tests? You gotta have a baseline cortisol, because what are you gonna compare it to if you don't? So remember, you always gotta draw a baseline cortisol. And you try to keep the animal as calm as possible, so you don't get too much of a stress response in those animals and that, okay? And this is just showing you basically what this is doing. When you give this exogenous dexamethasone, what's it doing to the pituitary and the hypothalamus? Because it has the same negative feedback as cortisol does. So if the pituitary is all right and the adrenal's all right, what should happen to your cortisol levels? Everything's normal, they're going to drop, right? Because you're not getting that, you're inhibiting the activation of the adrenal, right? Now, but what if it's hypo? What's that going to do if it's hypo? Okay, let's look at it. Is it hypo? Is it going to get even worse? Or you may not see any change at all. Would we use a dexamethasone suppression test for hypo? No, that's why the ACTH-STIM is the test of choice for all species to diagnose hypoadrenal corticism. Whereas with the hyperadrenal corticism, we can use the ACTH-STIM. It's the preferred one in the cat. The problem with the dog is if you do that, when you're doing ACTH-STIM, how do you know if you get increased stimulation? You should increase levels, right? But in the dog that has hyperadrenal corticism, the adrenal gland is so hypertrophied and everything, there's no reserve left to respond to any more ACTH. So in that case, if I give ACTH, will I see any change in my cortisol level? No. If we do, that gives us a diagnosis. If we don't, it does not eliminate the diagnosis of hyperadrenal corticism. That's why the low-dose dex is preferred in the dog. Okay? Now, with the low-dose dex, what you should see in a normal animal, if you give low-dose dex, you should see your cortisol level falling below 1.25 micrograms per deciliter. If it does not, it tells you it's not normal. So you do have hyperadrenal corticism. Okay? But you still don't know which one. Alright? So, this is just showing you an interpretation. You all can read that. So what are you going to do to tell you which one? That's the high-dose dex, and that is for all species, including the cat. And the high-dose dex is about 10 times higher than the low-dose dex. And basically, it is used to differentiate between pituitary-dependent and adrenal-dependent hyperadrenal corticism. Okay, and again, if we have hypoadrenal corticism, are we going to do this test? It's already not working. Do we want to suppress it even more? Okay, so that's why we don't use it for that. So with the high-dose dex, what if I have adrenal dependent? Is it going to care less about losing ACTH? No. So would I see any decrease in my blood cortisol levels? No. What if it's a pituitary tumor up here who does not respond to negative feedback? Is that going to give me any decrease in my ACTH levels? Or my cortisol levels, really? No. What if it's a normal tumor up here that does respond somewhat to negative feedback? You should see about a 50% or greater decrease in your baseline cortisol. If you do that, that is definitive for a pituitary-dependent hyperadrenal corticism responsive to negative feedback. Now, that works good in the dog, because most of them are. But what about a cat? Most of them are. What about a horse? Most of them aren't, because mainly they're pars intermedius and they don't respond to it as well. So what could you do? Now I do my ACTH-STIM in this animal, and I get 10 times increase. So I have hyperadrenal corticism, right? I do a low-dose dex, and I don't decrease it below 1.25. So I know I have hyperadrenal corticism. I do a high-dose dex, I do not get a decrease, 50% or more decrease in my cortisol level. So now what? Now I found out where it is. Could be a non-responsive tumor in the pituitary, right? Or it could be primary, couldn't it? What could I measure to determine which one? Endogenous ACTH. If it's the pituitary, what's causing the hypergonadism? Too much endogenous ACTH. If it's adrenal, what would my endogenous ACTH be? Low, because it's getting negative feedback and the adrenal couldn't care less about the ACTH, could it? Does everybody follow that? Please review that, because that's the whole basis in interpreting the different cases and stuff as far as clinical cases of hypergonadism and hypergonadism. Okay? And again, that's what we just talked about, and this is just showing you what it works. Okay? And basically, if it's adrenal thing, is it responding? No, say X's. But is the adrenal cut down the cortisol any? So look at this space. See what happened to the size of the cortisol level there, the print there. Got really small, right? Which means we just suppressed it, right? What about the name cortisol here? Did we do anything to it? No, so that tells it couldn't, because where's the lesion? Where's the tumor in this thing? See the tumor there in the adrenal gland we're doing? It's a little round circle, that's a tumor. I'm sorry I'm not more artistic, but that's a tumor.
Oh my God.
Okay? Okay, now you can, why don't we do a CRH stimulation test? What were we trying to find out? What was it?
Big one.
Okay. So what did we do a CRH stimulation test for? Can we differentiate between pituitary dependent and adrenal dependent?
You would look at your ACTH levels and your cortisol levels?
If we have pituitary dependent and we stimulate it even more, what's going to happen to our cortisol levels? Go crazy. But if it's adrenal dependent, could it care less about CRH or ACTH? So you're not going to change it. Also, what if we have tertiary hypoadrenal? Could CRH and then we get increase in our cortisol levels? Could that confirm that it's a tertiary problem up here?
Yes.
Because we gave CRH, that caused, if it's responsive pituitary, it released ACTH, responsive adrenal, it released cortisol. Cortisol levels went up. So where does that tell you our hypoadrenal problem is? In the hypothalamus. Now it doesn't always work, but that's what we need to do it for. Okay? Metiraprone. This is another compound that's used to differentiate pituitary and adrenal-dependent hypergonadism when everything else fails. And the reason for that is because metiraprone can kill the animal if you're not careful with it. So you don't want to use it as your first test. Well, if you kill the animal, you're doing necropsy, you can get what you diagnose it, right? Doesn't help your client much though, does it? So anyway. But basically what you're going to do is to take a plasma sample for cortisol and the 11-deoxycortisol metabolite of it. You give metiraprone to it orally every 6 hours for 4 treatments, which makes it even more problems to give. And then you take a second sample for cortisol and the 11-DOC 6 hours after your final dose of metiraprone. If you're in pituitary dependent, plasma cortisol will decrease, but your plasma 11-DOC, which is the metabolite which goes to make it, will increase. And ADH, both of the values will decrease. But again, you got to take because of the potential for morbidity and mortality. Because one thing that causes an abrupt lowering of cortisol levels, and that too much cortisol can kill you, but if you drop it too quickly, it can kill you also. And what have I told you a diagnostic test should not do? Kill the animal. Okay? Don't tell my husband I said that. Dr. Tippett or anybody. Anyway. Okay, so those are the tests. And so we're going to go, while we use these tests, we're going to go through hypoadrenal first. Then we'll go through hyperadrenal, and then we'll go through some of the miscellaneous problems we see with the adrenal. Okay? Gonna start a little bit and then we're gonna quit, but look at hypoadrenal corticism. Primary hypoadrenal corticism is the most common type of hypoadrenal corticism and usually results from a disease. In other words, peritonitis is kind of common in some animals and stuff. Right, tumors can invade it and everything like that. So, but you have to lose more than 85 to 90% of your adrenocortical cells before you're going to see clinical signs. So you think you're going to usually diagnose this very acutely? Is it going to be after the thing has gone basically to the end before you can diagnose it very often? Secondary hypoadrenocorticism is less common, and that's a problem, of course, up in the pituitary problem when you get decreased ACTH secretion. And if you don't have that, what kind of change will you see? If you have secondary hypoadrenocorticism, what change will you see in the adrenal gland? As far as the cortices. If they're not getting stimulated, what are they going to do? Atrophy. So that's what you're going to see in there, okay? But again, with the secondary, the zona glomerulosa is usually spared, so you don't see the problems with the mineralocorticoid. So you don't see a bunch of the electrolyte abnormalities. If I have an animal that has hypoadrenocorticism, you're saying, you know, low sodium, high potassium, what do you like think it is? Is it pituitary or is it adrenal problem? It's going to be primary, it's going to be adrenal. Because with the secondary, you don't see that. Okay? And this is adrenal on the top is a normal. What about that one on the bottom?
Very small.
Okay, that was Addison's disease down there. And basically what happened was, what's supposed to be thicker, the cortex or the medulla, in volume-wise? You're supposed to have more cortex, aren't you? What do you think about that one down at the bottom? Got a lot more medulla there in there, don't you? Here's this logical section of a normal adrenal gland on your left. What about that one on the right? Do y'all have to have pathology to know that's not normal? What happened to the cells? They're gone. Okay. And you notice it's this is all across as far as that. Okay, so again, primary hypoadrenocorticism is called Addison's disease, and it's the failure of the adrenal cortex to secrete your glucocorticoids and your mineralocorticoids. Also your sex androgens to a certain extent, but basically they're not that important as far as the overall animal is concerned. Most commonly results from immune-mediated infectious vascular chemical agents that basically damage the adrenal cortex, and then you have the death of the cells, atrophy, etc. Most common cause in cats is idiopathic. Is that surprising? What's idiopathic mean? You don't know. It says idiopathic adrenocortical atrophy. And one common cause of hyperadrenocorticism in cats is idiopathic adrenal hyperplasia. So basically that's strange. It can develop following overdosage with the adrenocorticolytic drug OPDDD, which is used in the treatment of hyperadrenocorticism. In other words, you know, with hyperthyroidism, sometimes you give drugs to destroy the thyroid cells. If you overdo it, what do you end up with? Hypothyroidism. If you have an animal that has hyperadrenocorticism and you're using the drug which gets rid of those excess cells, if you overdo it, what are you going to get? You overdo it, you get hypoadrenocorticism. Okay. And this is a microscopic comparison from adrenal for an animal that has bacterial septicemia. What's all that red stuff in there?
Blood?
Right, got a lot of hemorrhage. This is a section on the other side. It's from immune-mediated. Where are all those little dots in there? Lymphoid cells and stuff. And basically what is happening to the adrenal cells? Being destroyed. As far as your incidence, primary hypoadrenocorticism occurs uncommonly in dogs, but is the disease most small animal practitioners see. So why is that? With primary hypoadrenocorticism, you lose all aldosterone, right? So what's the animal going to go into? Is it going to lose its appetite or something, or is it going to go into hypovolemic shock? And what's the owner going to be more alarmed about? An animal that's eating more food or something, or is getting a strange haircut, or is flat out on the floor? So which one are you more likely to get brought into the clinic? The one with the more severe signs. And that's why, even though its incidence is not that common, as far as the whole gamut is concerned, what you see in the clinic, it's one of the more common. Does everybody follow that? It's because of the severity of the symptoms you see with it, okay? It's rare in cats and wasn't reported until 1983. Incidence has increased in cats over the years, but it's still not as common in there. As far as the signalment, the majority of your affected dogs are young adults, but what gets me, we have an age range of 3 months to 14 years. Is that much of a narrow range? Most of them are about 4 to 4.5 years old, but you can see it as early. In other words, with this, you can see very early in there. Sexually intact female dogs have a greater risk of developing the disease than spayed females, but sexually intact males have a lower risk than neutered males. So just the opposite as far as that's concerned. Any breed can be affected, but the Portuguese water dog, Great Dane, West Highland White Terrier, Standard Poodle, the Leonberger, Wheaton Terrier, Rottweiler, Springer Spaniel, German Shorthair, Pointer, and Basset Hound breeds seem to be at increased risk. The age of affected cats varies from 1.5 to 14 years, again, wide range. And all have been domestic long-haired or short-haired with no sex predilection. So it's not really considered to be a genetic situation as far as cats are concerned. And this is just showing you the Portuguese water dog. Let me see the different dog breeds in there. All right, some of the rare ones we see. Okay, clinical signs on dogs are often vague and suggestive of more common disorders, which is renal failure, GI tract or infectious diseases. There's no pathognomonic signs, but the signs will vary in severity from animal to animal. In other words, can other things give you hypovolemic shock and stuff like that? So, you know, but a lack of both mineralocorticoids and glucocorticoids can cause all kinds of